Talk with the Doc with Dr. Timothy Licklider of Allegheny Health Network and the Cowett Center for Comprehensive Parkinson Care. I think most of you have been on before, and you probably know Dr. Licklider at least from his talks and maybe as your neurologist. So welcome, everybody.
And thanks
Stay
for
out of the ice and snow.
That's right. Get home. I was gonna say, get somewhere safe before it gets bad. And welcome back, David. I know I'll speak for everybody who's muted, but we all missed you.
Yeah.
So it's good to have you.
I actually got back into the office this week. I'm finally allowed to start driving again. So
good. Well, it's good to have you back. That's for sure.
Thank you. It's great to be back.
All right. Well, I am Dr. Licklider, as usual. Most of you, I think, I've probably seen before or have been on here before. But if not, if you're new, this is your first time, welcome to the party. I'm Dr. Timothy Licklider. I am a self-appointed movement disorder. No, I'm just kidding. I did a fellowship. So I'm fellowship trained movement disorder specialist at Allegheny Health Network, which ultimately means I'm a neurologist who did an extra year of movement disorder so I can take care of people like you a little bit better. This is really a question and answer session. And so if you do have questions, type them in the chat box because I'll be watching over there. I have a couple that we got beforehand, which I'll start with, but put your questions in the chat box and I'll pick them off as they come in or as we go down the line. Few rules for food for thought, rules of the game, call it whatever you want. At the end of the day, what I usually tell people is this is not a great place for one-on-one recommendation. So what I don't like to answer is, hey, I've had Parkinson's for this, and I take this, and this medicine. What do you think I should do next? Well, that sounds like a really good conversation for your doctor. Either your PCP, hopefully not your PCP, hopefully you at least see a neurologist. If not, you're a movement disorder specialist. But again, the key here is really communication is really key to success between you and your doctor. So I highly recommend at least a neurologist, if not a movement disorder specialist, to really take care of you. And those are good questions for them. The other caveat that I like to throw out there is everything that you hear tonight, this evening, I don't know when it's considered night, is my opinion. The good part about what I do is the bad part about what I do, which is there's not a lot of black and white answers. There's a lot of gray area, which gives me a lot of room to make stuff up. I generally give you the answers to the best of my knowledge. I like to think that my knowledge is generally based in scientific data to the best of my abilities, but sometimes it isn't. And sometimes I just give you my opinion and I make it up. Usually if I'm completely making it up, I'll throw up some quotation marks and let you know that, hey, I'm making this up. But it's important to know that everything is really an opinion. You may go see a different neurologist or a different movement disorder specialist, and they may have a different opinion than me. There's not a lot of definitives, that's not a word, definitives or definites, or a lot of black and white in movement disorders. And so everything you get from whoever it is you go to is going to be their opinion. And you really just have to go with somebody you trust. So have good open dialogue with your doctors, recognize it's all opinion, and we do the best that we can. That being said, let me get started here. So there was a few questions, one of which was based on, and I don't know if this was let me take a look here. So this was out of the Michael J. Fox Foundation, but it was in the AARP magazine, maybe Brain Health and Wellness. And it looks like it was from December, where they kind of went over a few things that was, I guess, kind of maybe it was the year-end review of some different things that had come up with Parkinson's disease. And the one that was specifically asked about was really the probiotics and the gut idea part of it. So in this, and this just kind of broke down or gave you kind of the big picture topics about a bunch of different things. So it covered, high intensity cardio and exercise, which I love, personalized genetics, gut microbiome, biomarkers, DVS. I mean, so this article that I was sent, really covered high view of a whole lot of things, but what was specifically asked was about the probiotics. And what it reads is, it says, recent studies have found a possible link between Parkinson's disease and an imbalance of bacteria in the digestive tract. Now, we've been talking about the digestive tract and Parkinson's disease since the beginning of time. We know that it is intimately related in Parkinson's disease. This is why most people start, even before they develop motor symptoms, with constipation or GI problems. We know the enteric nervous system for the gut has a huge amount of dopamine neurons or nerve cells in it, and it's obviously intimately related in everything Parkinson's disease. We think it may even start there. We're not sure about that. We're still working it out, but so that part of this sentence really isn't all that exciting. Somebody's specific lab had discovered 2 common ingredients in over-the-counter probiotics are overrepresented in the guts of people with Parkinson's disease. And they follow that with a quote that says, "I worry about people with Parkinson's disease who are self-medicating with probiotics," which I thought was interesting. Then they went on to talk about H. pylori and how it interacts with Cinemet and more or less a different kind of gut topic. And I thought that was a little bit interesting because, again, I get asked about probiotics all the time, because the gut and the GI system is so involved in Parkinson's disease. It causes a lot of problems, constipation being just one, but the entire GI system, top to bottom, gets affected. Swallowing problems, esophageal problems, stomach emptying problems, gut motility problems, constipation problems. So basically, top to bottom, you can get a problem, and a lot of people have problems the entire top to bottom. And so we've been studying this, we've been looking at this. There was an idea that the bacteria in patients with Parkinson's disease is different than the bacteria of patients without Parkinson's disease in the GI system, and maybe probiotics would help correct that. I've seen a few reports on probiotics, although at the end of the day, I can't say that I've seen anything earth-shattering or overly exciting or anything that makes me say, yes, every single patient that I see with Parkinson's disease, I'm going to make sure they take this probiotic. I mean, there's some evidence to say it makes sense. And so I'm not against it if my patients take probiotics. But so I wasn't exactly clear what they were saying in this article as to whether or not it was a problem that people with Parkinson's disease were taking probiotics, and that's why they ended up with these 2 specific gut microbes. But at the end of the day, my opinion on probiotics is kind of the same opinion that I have on a lot of over-the-counter supplements or other things, is generally they're probably not harmful. There's some science and literature to suggest that maybe they're helpful. There's not enough for me to say, yes, everybody should do this. And this is what you'll find in a lot of over-the-counter supplements or probiotics or free radical scavengers or antioxidants or vitamins or diets included. It's really hard to study these things, and it's really expensive to do trials. And so to think somebody's going to put up $1 billion to do a trial on a probiotic seems pretty unlikely. And so we're never going to have the gold standard, good, high quality data to say, yes, this is what you should do, or no, this is what you shouldn't do. And it's just something that we have to live with in the world of supplements. And so my short take on that, a little bit about the probiotics, is that, maybe there's some evidence to suggest they help, or there's some at least science and logic behind why they could help. If you want to take it, or if you're taking it, you feel like it helps you feel better. If you want to try it and see what happens, be my guest. Usually what I say about all of these things is don't put yourself in the poorhouse trying to take these supplements or these probiotics or anything like that. Use your best judgment. But generally, they're all fairly safe. And so I don't have a problem if people do take things like that to see if it would help. The other question.
Can I just say something along those
go
lines?
for it. Go for it.
Casey and I confirmed our speaker for the conference. It's Dr. Samantha Evans, and she's with the Seattle Integrative. What is it, Casey? Seattle Integrated, and she works.
Seattle Integrative Health, part of Bastyr University.
Yeah, and that's Dr. Mishley's group, and she does a lot of research, and her research right now is kind of focusing on the gut brain and probiotics. And she said it's changed a lot recently, what they've found out and what they're thinking. So if anyone is really interested in learning more about that, she'll be at our conference. And then there's also going to be a workshop the following day for folks that want to drill a little deeper down into some of the things that she's going to hit on at the conference.
So the take-home message is go to the conference and make sure you ask her that question.
Well, yeah, and I'm sure she's going to bring it up, but yeah.
Most likely. Or
But
maybe
I
I'll go
thought
to
it
the
was
conference and
interesting.
I'll ask her that question.
There you go. And, but her response was that the research is changing. So it might be that initially they were recommending certain probiotics, but, that might be changing. So this will be interesting.
And that's definitely the good part about research is, so again, much like I said, everything's kind of my opinion. My opinion changes as new research comes out and tells me that my opinion should change. So again, that's the good part about what you're hearing out of there. The only other question that I got emailed to me was about dystonia. And so dystonia really is a term that means abnormal muscle contractions leading to fixed and twisting postures. And so it really is a cramping condition that leads to tightening up of muscle groups. And it can be associated with Parkinson's disease, which I'll come to in a second. But the question was, does dystonia typically have pain with it? My pain in my left leg seems to intensify when my meds are wearing off. Does this sound like dystonia, or does it have to do more with rigidity in the setting of off times? Or putting pressure on the sciatic nerve. And again, we've talked about pain before. Pain comes in a whole bunch of different varieties in people with Parkinson's disease. And so it could be any of the above. The keys to trying to figure this out are really paying close attention to it. So it's a wearing off phenomenon, which usually means it's a muscle cramping or a muscle spasm or a stiffness type of problem. But a lot of people do get dystonic posturing when their pills wear off. And so a lot of my patients will complain about toe curling or cramping, or arm cramping or fisting when their pills wear off. And that's usually what we would classify as a dystonic posture. There really isn't much difference outside of a technicality between kind of just cramping and dystonia. So if you have a lot of hard cramping or rigidity because you're wearing off, one person might call that rigidity, one person might call that dystonic spasms. And at the end of the day, it doesn't really matter what you call it. All of these are really just descriptor words. Dystonia is not really a great diagnosis. It's just a description of what we're seeing. Tremor is not a diagnosis. It's a description of what we're seeing, as are all the other words that you'll hear me use in my office. What we end up doing in movement disorders is we describe the movement and what we're seeing in a patient. And we use these fancy words to try to do that. And so regardless of what you call it, whether or not you call it dystonia or whether or not you call it just muscle cramping or stiffness or rigidity, in your case, it sounds like a wearing off, and it sounds like medication should be adjusted to try to make up for that. I wouldn't actually, so if I had a patient like that who was having these spasms or dystonia, I wouldn't treat it any differently if I thought it was dystonic posturing or if I thought it was just cramping or muscle spasms or rigidity. At the end of the day, I would try to find a way to make up for that wearing off time, because that seems to be when it's located. And so that's how I would look at that. I try not to get hung up too much on using specific words or specific nomenclatures, or really even labeling things with specific definitive diagnosis, because again, I live in a world of gray, not of black and white. I don't have a test for any of these things to confirm. And so I try not to label things specifically. I try to keep it more vague. That way everybody knows what I'm talking about, and it really, doesn't affect the way that we go about treating it. And actually, interestingly enough, that kind of segues into the first, question that I see up here, which is about motor fluctuations and kind of smoothing out ups and downs. Because again, in that case, if you're having a wearing off, so when your pills are kind of coming down and you're having a lot of muscle spasms or cramping, then that's knowing that situation really helps us decide what do we do about it. Because again, as you've heard me talk, there's always a lot of choices. There's not always good choices, but there's always choices, and trying to piece together your specific situation is the best way to try to figure out what the best choice is. And so getting to the next question, it was about experiencing increased on-off time. I supplement the on-off time with a drug that smooths out peaks and valleys. Can you generally comment on how dosages will react by under medication or over medication? Well, I'm not entirely sure what you meant by that, but at the end of the day, usually when you're under medicated, you do have more of these ups and downs. And when you're over medicated, you end up having dyskinesias, hallucinations. And so, again, trying to piece together when you're experiencing things, what you're experiencing, how do they relate to the timing of your medications, really helps us decide what to do. Now, I oftentimes get questions in my office that says, I hear all about this on-off phenomenon. I hear about patients in the support group or the boxing class that I go to who can feel their pills kick in and know when their pills wear off, and I don't have any of that. I get a lot of patients that come in and say, I don't understand what this whole on-off thing is. And I say, well, that's okay. You don't have to. On-off is not a requirement for a diagnosis of Parkinson's disease. For those of you who don't have that, a lot of patients do experience on-off phenomenon, which is they take a pill, it kicks in or it turns on, which means their symptoms improve. Their stiffness, their tremors, their slowness of movement, they feel better. And then as their pill wears off over whatever time frame it takes, they feel their Parkinson's symptoms get worse. That's what you'll usually that's what we usually understand, or you'll hear us talk about on-off phenomenon. Not everybody gets that. Not everybody feels their pills work. Not everybody has on-off phenomenon. Sometimes that's a good thing. Sometimes that's not a good thing. It doesn't really matter, but some people do, and that's what we're talking about. And what ends up happening as you progress in the disease, particularly if you're somebody who really does have these on-off phenomenon or fluctuations, is they become more frequent and more unpredictable. And so whereas, you kind of start the medicine and maybe you get this good response and maybe you don't even feel it wear off before your next pill, but over time and over progression of disease and increasing doses of medicine, you end up kind of having one of this where, where it no longer lasts to the next dose, you're kicking in, you're wearing off, you're kicking in, you're wearing off. And so I do get a lot of questions because some people don't experience that and they never understand it when people talk about it. There's a lot of things, excuse me, there's a lot of things you can do about that. And again, coming back to your specific situation would really be the best way to know what would be the best choice for you. You can just take pills more frequently. You can take longer lasting pills. You can supplement with another medicine. We can start talking about deep brain stimulator surgery or duopa pumps or other things that are more chronic, kind of steady state solutions. And so at the end of the day, if you are somebody who experiences these on and off fluctuations or phenomenon, bringing it up. So again, open communication with your neurologist, open communication with your movement disorder specialist, particularly the more detail you can give. It's a lot easier for me if a patient comes in and says, I take my pills every 4 hours. It kicks in after about a half an hour. After about 3 hours, I start to feel it wear off. When it starts to wear off, I'm stiffer, I'm slower, I'm shakier. That tells me a whole lot of information about how you're taking your medicine, how the medicine is working for you, how long it's lasting, and it gives me a whole lot of ideas about what we should do about it. If you come to my office and you say, yeah, I don't think the pills are working all that much, well, then I have to kind of tease out exactly what's going on. And so the key to success here is remembering, and I've said this before, I am not a mind reader. Maybe some other neurologists are mind readers, but I don't read minds very well. And so being as open as you can and really as detailed as you can. I get a lot of patients that will come in and say, I just don't feel all that good, or I'm having a lot of downtime. Well, that's useful, but what's more useful is, okay, how is it related to your medications? Do you feel your medicine's working? Do you think that this is a wearing off problem? Is it that you're stiffer and slower, or is it that you're freezing or you're walking is a problem? As detailed as you can get is really going to help whoever it is that's taking care of you figure out how to adjust your medicines or what else could we do to try to help you do better. The more vague you are, the more we have to mind read or guess, probably the less successful we're going to be. Does Sinemet lose effectiveness over time, especially against tremors? If so, what then? There's a lot of questions in that one. The short answer to your first question is maybe. I know, I'm so definitive in my answers. Does Sinemet lose effectiveness over time? We don't know. Either it loses effectiveness over time, or the disease progresses, because those would really be the equivalent, right? And so if you start shaking more, is it because your disease progressed, or is it because the medicine became less effective, or is it both? Probably both, but we don't really know the answer to that question. The short answer is yes. What I think you're asking is, over time, you generally do need more and more medicine because the symptoms become progressively worse and the medication becomes less effective. So I think all of the above is probably true. Usually what you see in kind of years of taking medicine and increasing the dosages of medicine is exactly what I just mentioned. So it becomes less effective in that where it used to last longer and have this nice smooth curve and you never really noticed it, you didn't feel it wear off, you forgot your pills because you weren't reminded that you needed to take them. Over time, it does become choppier. So it kicks in, maybe it even overshoots and you're dyskinetic, and then it comes back down, it wears off and you're stiff and slow again. And that does happen over time, the longer you're on the medicine and the higher the dose of medicine you're on. And so is that the medicine becoming less effective, or is that you progressing in terms of your course of disease? I don't know, probably a combination of them both, but it definitely happens. If that happens, what do you do then? Well, again, then you go back to all the same strategies that we have. And again, it determines, or it's decided by what we're trying to accomplish. You either increase the amount of Sinemet you're taking, Sinemet being carbidopa levodopa for those who are taking it, which is just about everybody. You can add another medicine. So we use pramipexole, we use Azilect, we'll use Comtan or Ongentys to smooth out the ups and downs. We'll use a Nupro patch to try to smooth out the ups and downs. We'll use amantadine to try to prevent dyskinesias or help you walk a little bit better. There's a lot of choices of medications that we can throw at you. Or if you continue to have problems, then we start talking about surgical interventions, deep brain stimulator surgery, the Duopa pump, which is infused levodopa into your small intestines to try to smooth out the ups and downs. But it really comes down to what are we trying to accomplish, and what's the best way for us to try to accomplish that. And so again, one of the hard parts about what I do, especially in trying to teach it to the next residents or the people who come up and spend time in my office, which is, I usually have somebody in my office who's trying to learn something, is a lot of what we do is individualized. And so there's not necessarily a lot of patterns. What I do for one person very well may not be what I do for the very next person that walks into my office. Because what makes sense for one person to try to smooth out ups and downs or help them do better may not be what makes the most sense for the next person. There may be a better solution for somebody. And I know everybody compares notes. Don't think I don't know what you guys do in your support groups and your boxing classes. I know you do. Which is fine. You just have to remember that just because so-and-so is on this medicine and it's working really well for them does not mean that that's the best choice for you. And this is what we talk about when you come to the office, or what you should talk about with your doctor when you go to the office. And so that's usually what you do when Sinemet or levodopa really isn't working the way you want it to. You have to figure out an alternative. I don't know the answer to that question. This is, and David, I'll let you answer the conference question at the end of the day, but I'm going to skip that one for now.
Yeah, I think I did.
Okay. Oh, I didn't get all the way down there yet.
Well, and I just sent it to Vicky and Donna too. I didn't
Even
send
better.
it to everybody.
Okay. Amyloidosis and Parkinson's disease in the same discussion. Not usually. So amyloid is a protein that can get deposited in the brain. And usually what we see when we're talking about amyloid angiopathy is you see a lot of microhemorrhages or small bold bleeds when you do an MRI scan or a CT scan of somebody's head. Amyloidosis can definitely play a role in or potentially lead to things like dementia. You'll hear amyloid talked more about in Alzheimer's disease, although again, those two are not one and the same, but you generally don't hear about amyloidosis in Parkinson's disease. And in fact, when I do a lot of scans of people with Parkinson's disease, we do a lot of CT scans, MRIs, I am not used to seeing a lot of amyloid angiopathy or a lot of deposits or a lot of microhemorrhages in a lot of my patients with Parkinson's disease. And so I'd have to look that one up to see if there's necessarily a relationship. All I can tell you is kind of in my experience, there has not been necessarily a big correlation between the two. And when I do imaging for patients, it's not necessarily something that I see commonly. Do I treat dystonia with Botox? Yes, I do. Specifically cervical dystonia? Yes, I do. Do I treat dystonia in Parkinson's disease with Botox? Yes, I do. Do I treat dystonia in Parkinson's disease or cervical dystonia without Botox? Yes, I do. Yes, I threw in a few extra questions there. I recognize that. But at the end of the day, yes, to all the above. So dystonia, kind of by definition, is a muscle contracting problem. And so again, if you think about what a lot of people with Parkinson's disease experience, probably the most common dystonic posturing I get is toe curling. Sometimes you get cervical dystonia, which is a head turn, a tilt, a multidirectional head tremor, but that's usually more of a standalone condition outside of Parkinson's disease, but it can be associated with Parkinson's disease. But probably what I get from a dystonic posturing standpoint in Parkinson's disease is toe curling. Now, this is a little bit of a lecture on Botox, but the short answer is Botox weakens muscles. So most people know Botox is a cosmetic thing. It smooths out wrinkles. I could probably use a little Botox myself, but it does so because it weakens muscles. So if you paralyze these muscles under the skin wrinkles, it flattens them out and then you don't have wrinkles anymore. Okay. The cosmetics people actually stole it from us. Now, we didn't invent Botox either. We stole it from ophthalmology. Botox was initially used in ophthalmology to help cross eyes. So there were patients who had crossed eyes. They could weaken the muscle that was pushing the eye midway, and it would straighten it out. They were actually, the ophthalmology team were the first ones to use Botox, I believe. Neurologists then stole it from them. Movement disorders picked it up because a lot of our neurological conditions or our movement disorder conditions have muscle contracting and cramping as a problem. And so if you take my word for it that Botox weakens muscles, that's how it works, you can then think about why we would use it for a muscle contracting problem. If you have muscles that are cramping and sticking or really contracting so much that you're having toe curling, if you weaken those muscles, i.e. by sticking Botox in there, you can relax them. The same thing is true for dystonia in the neck. If you come in and like this, I can weaken the muscles that make your head turn, thereby allowing you to straighten out your head. So that's why you'll see Botox used in a lot of these different conditions. And yes, I do Botox injections myself. I do them for dystonia. I do them for a whole bunch of things. It's not the only choice. And so there are medicines that can relax muscles or loosen up muscles. It turns out that a chemical outside of dopamine called acetylcholine is really the chemical that's impacted in muscle contraction. And so if you prevent acetylcholine, you can prevent muscle contraction and thereby weaken muscles as well. Botox is probably my favorite way to treat some of these problems because I liken it to a focal solution for a focal problem. Botox, if you don't know, actually it comes in a little vial. It's a white powder. We reconstitute it into a liquid, and then I inject it into whatever I'm injecting, your neck, your leg, your arm, your face, wherever I'm trying to get it. The good part about Botox is it stays more or less where you put it with some capability of local spread. But when you take a pill, it doesn't just go to your neck, right? It goes everywhere. This is what gives you systemic side effects. And so I like Botox injections better than medications for things like this because it's more of a focal solution for a focal problem. And so, yes, if you come to me and you say, hey, I have this dystonia or I have this posturing, Botox is at least going to cross my mind. Whether or not it's right for you, that's a discussion that we have. But it is something that I do for a lot of these different conditions, including dystonia and Parkinson's disease. I also do it for drooling, but that's a whole different conversation. I'm not entirely sure how it works for that, but it does. As PD progresses, can there be an increased cravings for sweets when somebody didn't normally eat them? That's an interesting question. And the short answer is yes, but I would also be interested in your medications. So why do I say yes off the bat? Well, when we think about dopamine, you know, everybody in this group who's on this line thinks about dopamine in terms of movement, right? Dopamine is what we talk about. Dopamine is what's missing in the substantia nigra. You can stain people's brains. It should look black. It doesn't. That's why we know that it's lacking. And generally, we think about dopamine in terms of movement. However, dopamine actually does a whole bunch of stuff in the brain. It's not just making you get up and walk. Its main role in the brain is actually reward, believe it or not. And so dopamine is the reason you keep playing the slot machine. You know, you just think next one's going to be the one that I hit it big. You know, it's the reason you go to the craps table. You know, it's the reason we like to eat candy. It's the reason that we do things that are pleasurable. So dopamine is actually really big in the reward pathway, in the limbic pathway. And likewise, that pathway can be affected in Parkinson's disease as well, and not always in a good way. So you would think lack of dopamine means maybe we wouldn't have those types of tendencies or that need for sweets. However, what I find is that that's not always the case. And that's that's regardless of what medicines you take. Now, the medicines also play a role here, right? So we're replacing dopamine. And dopamine, again, much like the medicines that we give you for the cramping that I just talked about, dopamine doesn't just go to the movement pathway. It goes everywhere. And some of that everywhere involves a reward pathway. And while you don't see it as much with levodopa as you do with, say, Mirapex, it can actually cause some sweets eating, we'll say. It can actually cause some impulse control problems. In fact, a black box warning of the dopamine agonists, i.e. pramipexole, ropinirole, rotigotine patch, is impulse control problems. And so generally the four that we think about are gambling, sex, shopping, and eating. And so I would be interested more in which medicines you're using to treat your Parkinson's disease that progresses, because I will tell you, Mirapex comes with candy eating. A lot of my patients come back and say, man, I put on 10 pounds and I have no idea why. And I look and I say, oh, well, it's because you're taking Mirapex and now you eat ice cream every day. This is not an uncommon problem that I run into. And so the short answer is part of it is the disease itself, because dopamine is so prevalent and so important in the reward pathway. But the other part of it really is the medications that we then use to treat these problems. And it is something worth pointing out or noticing. Again, the good part about something like this is most of my patients are skinny. They're underweight. And so I end up telling them, eat the candy, eat the ice cream. But if that's not the case for you, then you do have to be a little bit careful. What do you see on the horizon as promising research that could end up reversing or even curing Parkinson's disease? Well, I used to answer this question differently. And so I used to say the closest thing we are to something like that is stem cells. And again, the logic being that if the reason you get Parkinson's disease is because the cells that, are in certain areas of the brain die, theoretically, if you could convince stem cells to become those cells and replace those cells, you can kind of get the idea for why it would be that. But I've actually read a few things recently where there wasn't a lot of optimism in the stem cell realm. And it turns out, at least the last thing that I read, which was probably a couple of months ago, was talking about how stem cells probably aren't the way of the future, because we now know, and the more we learn about Parkinson's disease, is it's not just dopamine. We've spent the last 200 years talking about dopamine, and all the medicines that we used are aimed at dopamine. And the cells that we've stained that we know are missing make dopamine. But it turns out it's not as simple as that. And I think actually Michael J. Fox himself is coming to this realization, is it's not nearly as simple as they thought 20 years ago, 30 years ago. It's probably not even as simple as we thought 5 years ago. Now we're learning more and more that it's not just dopamine that's the problem. Serotonin is a problem. Norepinephrine and epinephrine are a problem. It turns out that this is actually a much bigger or global problem than just, oh, you lose the cells that make dopamine in the substantia nigra, and that's what gives you the symptoms. And so the problem with stem cells is we can't figure out how to replace all the cells that are missing or all the different chemicals that are missing. And so I think that's kind of getting a little bit trickier, although they're still working on that. Don't get me wrong. They're still working on stem cells and seeing what we can accomplish with that. The short answer, and this is not a short answer, there is no short answer to your question. My opinion, so everything you hear from here on out is my opinion, is that we are a few steps away from beginning to figure out how to reverse or cure Parkinson's disease. And so what do I mean by that? Well, my first opinion is that Parkinson's disease is not a disease. Parkinson's disease is a syndrome. And you might say, Dr. Licklider, I can't even say my own name. That's a technicality. Stop trying to get fancy here. What do I mean by that? Parkinson's disease is a collection of symptoms, right? You get diagnosed with Parkinson's disease because you have tremors and stiffness and slowness of movement and balance problems. And we don't find any other cause for it, and you respond to medications. But realistically, when you're talking about a collection of symptoms, that's actually the definition of a syndrome, not a disease. So it's a little bit of a misnomer. The problem with it being a syndrome and not a disease is it's not just one thing. And this is the problem that I think we keep running into. is anything or any combination of things that leads to the symptoms of tremors and stiffness and slowness of movement and balance problems gets labeled Parkinson's disease. And so here's the problem with that as a philosophy or as a thing. Let's say I have here the cure for a specific type of Parkinson's disease. So let's say this here, which is actually just water. Turns out water is not the cure, by the way. I'm not saying water is the cure, but let's pretend it was. And let's say that this cured the LRRK2 variety. So that's a genetic form of Parkinson's disease, but let's just say that's what it cured. And it cured it. But now I have to test it. And I'm going to test this as a cure for Parkinson's disease, because let's say I didn't know about LRRK2. Let's say this is a cure for some other genetic variant or some other specific type of Parkinson's that I don't have a test for. And let's say I could fix it. I'm going to test this in everybody who has Parkinson's disease, right? So everybody who gets enrolled in my trial for this cure here is going to be everybody who has Parkinson's disease. Well, the problem with that philosophy is everybody that has Parkinson's disease actually has a bunch of different things. And so even though I can cure, we'll say 5% of them, I have the cure for 5% of them, the other 95% of them are going to make it so this looks like it didn't work, right? When you do a study, it's going to get washed out by the people that this doesn't cure, because Parkinson's disease is not one thing. I really do think Parkinson's disease is a whole bunch of different things that all ends up looking the same. And why that's a problem is exactly what I just mentioned. So when you do a test for a drug, even if you have the best drug in the world for a specific subset, it's not really going to prove to be that effective unless you test it in that specific subset. If you try testing it in everybody who has Parkinson's disease, it's not really going to be that effective, or you're going to lose the disease modifying benefit or the curing benefit. And so the steps that I think need to happen before we get to what you're talking about, which is reversing or curing Parkinson's disease, is a few steps. One is we need a reliable biomarker. And what that means is right now we do not have a biomarker for Parkinson's disease. There's no blood test, there is no scan, there is no test that I can do that says, here is your Parkinson's disease and here it's progressed to this amount. We need that. We also need different biomarkers to differentiate between the different types of Parkinson's disease. So now we're talking about precision medicine. This was the whole idea behind the Human Genome Project. It's the whole idea behind all the genetic work that's going on. We need to get down to the details or the finite reasons for why you developed what you have. And then we need to start testing things on individual groups of patients that all share the same thing. And that's how we're going to get to that. Because again, I really do think that there's a lot of different things that are all led or called Parkinson's disease, and they're not all going to respond to the same thing. In fact, it may be a combination of things that you need, but they're not all going to act the same. They don't all progress the same. They don't all respond to the same medicines, and they're not all going to be fixed the same. And until we start differentiating these people in advance, we're going to have a really hard time proving that something reverses or cures Parkinson's disease. So that was a really long answer for a relatively short and simple question, but that really is my philosophy. I really do think we have to do this in steps. We need a test. We need a reliable biomarker. We need to start being able to differentiate people with Parkinson's disease into whatever it is they actually have or the subgroups. And then I think we can start targeting each of those things individually. That's going to happen. Everything that I just said is going to happen. Just not today or tomorrow. They're working on all of these things. There really is progress in all of these realms. And I really do think in the future, don't ask me how long in the future, because I'm not very good at predicting. They told Michael J. Fox it was going to be 5 years before they had a cure for Parkinson's disease. And he was diagnosed about 30 years ago. And they're still telling him 5 years at least. And so I'm not going to put a time frame on that, but I do anticipate in the future, this is what we're going to be doing, and this is how we're going to be taking care of patients. And so again, that's a very long-winded answer to what I think is a really important and good question. It's just not as optimistic as everybody on this call would like. And believe me, it's not as optimistic as I would like to be. I would like to tell you that yes, stem cells are the answer. This is going to be the fix, or this infusion is going to be the answer. Dr. Van Laar is doing great work with infusions directly into the brain, which is resetting the Parkinson's disease cycle to some extent. I'd love to say that that's the fix or that's the cure, but I'm not entirely sure we're there yet. I am optimistic that we will get there at some point. I just don't know when that point will be. Good question, though. What is the best treatment or therapy or advice for someone with Parkinson's who experiences slowness with their feet? Also, do I need to be concerned that this slowness will cause a problem while driving? Probably. Do you need to stop driving or be like, oh my goodness, this is, no, not yet, but do you need to be concerned about it? Probably. Driving is always a tricky question in my office, and nobody ever likes the answer. The first part of that question is a little bit trickier though. Again, so what is the best treatment, therapy, or advice? Well, the best advice is pay attention to your symptoms. If you're on medicine, how does it relate to your medicines? Is this a wearing off and you need more medicine? Is this a dyskinesia and you need less medicine? Does it have no impact from the medicine whatsoever? In which case we need to think of something different. Is it a structural problem? Are you slow in your feet because you have a bad back, or you have sciatic nerve problems, or you have neuropathy? All of these are very common things in anybody who gets older, and so you can imagine they're common in Parkinson's disease patients too. I didn't just cure anything, don't worry. And so step one is really paying attention to your symptoms and paying attention to all the things that we're going to want to know, or you're going to want to be able to tell us to try to figure out what we do. Now, obviously, and I shouldn't say obviously, because maybe you don't know me and maybe you've never been on this video before, but obviously exercise is the best answer. Exercise is my favorite thing to talk about. It's always been my favorite thing to talk about. It's still my favorite thing to talk about. Still the best medicine we have, still the closest thing we have to a disease modifying treatment, slows things down, keeps you better longer, helps keep you upright. I could go on forever. I'm not going to, I promise. But so the best treatment, therapy, and advice is exercise. But after that, then we have to start thinking about what else can we do? Is physical therapy a better place? Maybe we need to get you to the big program or a physical therapist where they work on cueing. So if you do get stuck or frozen, you can get unstuck. Maybe we need to adjust your medicines to try to make up for these ups and downs. Maybe we need to add in something different, because even though levodopa is still the best drug we have for Parkinson's disease, it's not all that effective for walking in balance. Sometimes I'll use amantadine. Sometimes I'll use Exelon. Again, these are just all ideas that I come up with when I'm trying to figure out how to get somebody walking better or less stiff and less slow. And so at the end of the day, there's really no one best, outside of exercise, there's no one best therapy or advice or treatment. It really comes down to you individually. And so I think at the end of the day, your best bet is paying attention to your symptoms. So you guys know your symptoms way better than we do. Even though I play the expert on TV or on your computer or whatever I am, you guys are actually the experts, because I don't have the disease. I can't tell you what it feels like. You can. And so paying attention to your symptoms is really key to success. Seeing how they respond or reflect medications, seeing what makes it better, seeing what makes it worse, all the things that we usually talk about when you come to the office is really the best way to try to get to the answer to that question. Again, I would highly recommend exercise if you're not doing it already. When I do have people who specifically have slowness in their feet or freezing or hesitation or walking imbalance problems, I do rely heavily on physical therapy. And so that's something to take into consideration as well. So that's what I would really recommend in the office. Driving is tricky because at the end of the day, driving is multifactorial, well, just to put it mildly, right? When you're driving, it requires a whole lot of things to work and function correctly, not just your feet. And I'm really bad at figuring out who should or shouldn't be driving, in all honesty. The tests that I have you do in the office, and we do finger to nose testing, we do rapid alternating movements. I watch you walk and I see your tremor and your stiffness and I feel your joints and all the same stuff that we always do. Really is not a good test or indicator as to whether or not you're capable of driving a vehicle. And I always love it, and by love it I mean hate it, in case you're listening, when it's usually a family member, it's usually a wife, slips me a piece of paper or gives me a piece of paper before we go into the room that says, I don't think he should be driving, talk to him about it. And I'm like, all right. So somehow I have to figure out how to steer the conversation to driving without them knowing that you told me to steer it that direction, which is not easy to do, by the way. I would much rather have an open conversation with everybody, but believe me, this happens almost daily, where I get notes and messages and things like that. It's not my favorite way to do it, but okay. And what it turns out is that the best way to know if you should be driving is asking the people who are with you. It turns out that I'm not all that great at picking up subtle things that mean you should or shouldn't be driving. But what I am good at is listening to other people that come with you. And so the way that I handle driving in my office for all of my patients is sort of a cop out, believe it or not. It's really to make it so I'm not the bad guy, because probably the number one thing as neurologists that we do that makes people angry is take their license away. Now, usually we deal with that more in epilepsy and seizures, but it's not uncommon in this realm to do it as well. But if you really want to make somebody mad at them, tell them they can't drive. Happens all the time. But so the way that I do it is I ask how you're doing. And the good part is most of my patients come with somebody else. They come with a significant other, they come with a child, they come with a caregiver, they come with a close friend. And that's really, really helpful. And the way that I do it is I say, well, okay, do you think you can drive, or are you safe driving? And of course they say yes, because everybody thinks they're a good driver. And then I turn to whoever's with them and I say, do you think they can drive? Do you think they're a safe driver? And naturally, if they both agree, everybody's happy, right? If they both say, oh yeah, you can drive, it's not a big issue, fine, you can drive. And obviously, if they say no, if both of you say no, I can't drive, well, then you don't drive. That's pretty easy. And you can imagine where we run into a problem, which is not all that uncommon, where of course, Mr. Smith says, oh yeah, I'm a great driver, I can drive, no problem. And of course, Mr. Smith's wife or daughter, it's always daughters, never sons, comes in and says he absolutely should not be driving. That's when we run into the problem. And of course, I have an easy solution for that. That doesn't make me the bad guy. I send you for an on-the-road test, which you can do at a driving school. And if you're in the crowd listening to this conversation and you're in that situation where you're saying, oh, I can drive, there is no problems with my driving, and your husband or wife is sitting there saying, no, you can't, they're usually right. I have probably sent, I don't know, a dozen, maybe 24 people for an on-the-road driving test because we ran into that situation and I couldn't convince the patient that they shouldn't be driving because they were adamant that they were a safe driver. And so I prevent myself from being the bad guy and saying, no, you really shouldn't drive. And then they're mad at me by putting it on the driving school and making you do an on-the-road test. But I do caveat by saying, if you go take an on-the-road test and you pass, I will absolutely back you up and say you can drive. But in the maybe dozen or 24 people that I've sent for an on-the-road that I have sent for an on-the-road test, I have had a whopping pass rate of 0. Not a single person has passed. And it's not because the on-the-road test is so ridiculously hard that nobody can pass it. It's because significant others and kids and close friends and people who know you are pretty good indicators of whether or not you should be driving. And if they're telling you you shouldn't be driving, there's a reason they're telling you shouldn't be driving. And it's not because they hate you and they don't want you to drive and they really want you to be stuck in your house and take away your independence. Yes, all the stuff that you yell at me after I tell you can't drive about. It's because they really think you're an unsafe driver. I mean, people are really not all that quick to bring up driving concerns. And by the time they do, it's probably even later than we should be talking about it. But they're pretty good indicators that you shouldn't be driving. And you can argue the case and we can send you for an on-the-road test, which I still do to this day. But at the end of the day, just remember my pass rate is 0%. All right, I think I've talked about that enough. A documentary released in 2014 said that Alzheimer's disease and Parkinson's disease numbers would increase heavily in the next 10 to 15 years. Is that holding true? Yes. Are you having an increase in diagnosis? Yes. Is COVID delaying people seeking attention for symptoms? No. The number of Parkinson's disease, I believe I read somewhere, is actually the #1 increasing disease across the land. We have not caught up to Alzheimer's disease yet, just in sheer numbers, but we're #2 in terms of neurodegenerative conditions. And the number of Parkinson's disease patients, and I don't remember where I read this, this may be an opinion, you have to fact check me on this one, is that the incidence of Parkinson's disease is increasing at a more rapid rate than any other condition that they know of. And that's probably for a whole bunch of reasons that I don't even begin to understand. People are living longer. There's probably exposures to things that cause Parkinson's disease. Genetics is playing a role. There's a whole bunch of reasons why the numbers are increasing. But yeah, the short answer is there is no shortage of patients. In fact, if you're my patient, you know just how hard it is to get into my office these days, because we are packed with patients, new patients, not just old patients. The number of people in the Pittsburgh area is going up. Really, the short answer is there is a dramatic increase in the number of people with Parkinson's disease, and it's going up every year. And I think even again, so that's 6 years ago. I would say even over the next 10 to 15 years beyond, you're still going to see a big increase. Now, COVID's interesting. So COVID, for a while, people weren't coming to the office, but now they've come out and people are generally coming to the office as much as they were before. But COVID is interested because we're still not entirely sure if that's going to lead to more Parkinson's disease. So tremor and Parkinson's disease is not the most common acute movement disorder in COVID infections. They actually get kind of dyskinetic or jerking movements. But if we look back at the last pandemic and the Spanish flu of 1913 or 14 or whatever year it was, and how that maybe led to the encephalitis lethargica outbreak, which was really the precursor to what we call Parkinson's disease. It does make you wonder. We're seeing a lot of similarities in actually symptoms of people who get COVID in terms of loss of sense of smell, how it affects, different symptoms and systems. And so I think it'll be interesting to see what happens to the number of Parkinson's disease patients over the next 10 years. If COVID plays a role in the development of Parkinson's disease, then you're going to see an outbreak of it. It's going to go up. If it's just incidental, then maybe not, even though it's still going to increase because the numbers are going up regardless of COVID. But I think at the end of the day, the short answer to what they said back in 2014 is holding true. And I think it's going to hold true for the foreseeable future because the numbers just keep going up and up and up. I don't think people are necessarily delaying seeking treatment or going to the doctor because of COVID, at least not anymore. Maybe it was a while ago, but not necessarily anymore. Why hasn't research narrowed the scope by limiting classifying the Parkinson's population in a very narrow geographical location where there is at least common environmental elements? It's not a bad idea. And part of the reason is generally when you're doing big studies, they're multi-center. Sometimes they're national and international. And so you do get patients that come from a lot of different places. But there are other countries like Italy does a lot of studies where they're fairly close together. Denmark, Sweden, these smaller countries are smaller. And so their environmental differences are maybe more regulated. The short answer to that is I don't know. It's not a terrible idea, but then you have to be able to collect enough patients from a similar geographic area to power the study well enough to get the answer that you're looking for. And so that may make it a little bit trickier, but it's not outside of the realm of possibility, I wouldn't think. The same thing is true in terms of limiting based on symptoms. So for a while, you used to hear tremor predominant versus akinetic rigid, but it turns out that didn't really pan out in terms of really giving us a lot of information in terms of what works and what doesn't. More and more, you're going to be hearing about the genetics of Parkinson's disease. You're going to hear about LRRK2. You're going to hear about glucocerebrosidase. You're going to hear about, PARK1 and 2 and PINK and all of these genes that we're learning. And so at the end of the day, I think we're heading in that direction. It just takes time. We need to learn more and more about the genetics. So again, genetics is one of those interesting things. If you would have asked, what percentage of Parkinson's disease is genetic 50 years ago, we'd have said none, right? If you would have asked how much Parkinson's disease is genetic 20 years ago, we'd have said maybe about 5%. If you would have asked how much of Parkinson's disease is genetic about 10 or 5 years ago, we'd have said about 10%. You ask that same question today, it's about 15 to 20% now. You ask that same question in 50 years, we have a different conversation, right? And so the more and more that we learn about research and genetics and causes and underlying differences in genetic or, amino acids or gut microbiome or all of these different things, subsets, the more you are going to see tailored studies, the more you're going to see narrowed down research, the more you're going to see precision medicine, which is really what we want, right? The whole idea of precision medicine is that we do this whatever test, a scan, a blood test, and it says, this is the problem in this patient. And then I go to my shelf over here and I say, oh, okay, here's the cure for this problem. And I give it to you, right? That's the definition of precision medicine. Obviously, we're nowhere near that, but that really is the goal. And you do it by collecting subgroups, narrowing down your scopes and narrowing down your research populations and really drilling down to the finite details. And so again, you're going to see it more. You're going to hear about it more. Nothing that I'm talking about is me making, I'm actually not making it up this time, I don't think. Nothing about what I'm saying is really surprising. I think it is just the natural progression of what we're learning in medicine. You're seeing this a lot in oncology. So genetics is playing a huge role in cancer. You know, if you had breast cancer 10 years ago, you got grouped in and you got this medicine. Now, if you have breast cancer, they send it to the genetics lab and it comes with like 10 different markers, and that guides which drug you get. And so oncology is probably where you see precision medicine happening the quickest and the most. But I think at the end of the day, we're going to be following, hopefully relatively close behind, and we'll get there. But that's why I think you don't see it as more collecting enough people, and really we haven't figured out. I mean, geographical location is one, because you're right, environmental exposure plays a role, but there's so many other things that I think we need to account for. Have you heard that the COVID vaccine is going to cause more neurological symptoms? Maybe, I don't know. I hear that it causes neurological symptoms. I have patients that come to me specifically after they get the vaccine with a new neurological problem. I have a lot of my patients who say that their underlying neurological problems get worse after they get the vaccine. And so I don't know if that's what you're looking for in the answer to that question. I can't say that the CDC has come down or Mr. Pfizer has come down and said, hey, by the way, this is going to make your patients worse, or this is going to flare up your neurological symptoms, or this is about to cause a whole bunch of new issues for you. Heads up. No, that's not the case, but that's never going to happen, in case you were wondering. The vaccine's tough. COVID's tough. I mean, at the end of the day, I have patients that have had COVID or got the vaccine and their symptoms get worse. No doubt about it. Their tremor gets worse, their walking gets worse, their symptoms get worse. And I've had very, very many patients have no lingering side effects to getting COVID or the vaccine. So it's not everybody. And if you go online, I'm sure you can find all of the above. I'm sure there's whole chat groups and support groups for how COVID caused all of their lifelong problems, or the vaccine nearly killed them. I'm sure that exists, but I don't know, is the short answer. You know, nobody's going to come out and tell us this for a long time yet. You know, we're not going to have data to tell us this stuff for a long time yet. And if you ask my opinion, 10 times out of 10, I'm still going to say, yeah, you should get the vaccine and you should get your booster shot. And it's not because I think, oh, this is so safe that nothing bad can possibly happen to you, or because I've never seen somebody have a problem with the vaccine, or I've never had somebody come in and tell me that they got worse. None of that's true. I've seen all of the above. But I also round in the hospital where there's people with COVID dying. And so if I'm weighing out the risks and benefits, I see the people who get worse symptoms or who have problems after the vaccine, and I see the people that are dying from COVID, and I think the vaccine is the safer choice. That's my opinion. Not everybody might agree with that. So there might be a lot of people on this line that don't agree with that. There's probably neurologists that don't agree with that, or movement disorder specialists that don't agree with that. But just in my experience, what I've seen, I have seen many, many more deaths or permanent problems or really disabling issues from the COVID virus itself than I have from the vaccine. And so my recommendation to everybody who comes in is that they get vaccinated, because I still think that's the safer choice. Although, yes, I have seen patients who have told me that they got worse, that have new neurological problems after the vaccines. That is not outside of the realm of possibility. And then this last one here, I think, was just an update, right? So from 1990 to 2015, the number of Parkinson's disease sufferers doubled. From 15 to 40, they're expecting it to double again. And this is from Ray Dorsey, who wrote a book on ending Parkinson's disease, which I haven't read yet, but I've had patients tell me I should read it. It's on, you can't see my desk, but it's basically covered in sticky notes. I'm pretty sure books to read is on one of them. And so, yeah, I fully anticipate that you're going to see an increase in the number of patients. with or without COVID being the culprit, but just the fact that it is increasing and we're noticing this, it has come true, and I think it's going to come true. All right, with that, I think I'd answered all the questions. So I thank everybody for sending in questions. And guess what? As long as you guys keep having questions, I'll keep doing it. This is relatively entertaining and fun for me, so I don't have a problem with that. If we ever get to the point where you guys absolutely run out of questions and there is no more questions to answer about Parkinson's disease for anybody, then I'll hang it up and stop doing it. With that, David, I'll pass it back to you and let you finish us off.
Thank you so much, Dr. Leclerc. I think this is probably up around 25 programs you've done now, because we started. Really? It's got to be, because
2 years.
Started, yeah, getting close to it. I think,
wow.
Well, maybe a little bit shy of 25, because we started in September.
Well, good. That means that means nobody's running out of questions, and hopefully we're still doing a service.
The folks are leaving now, but at one point we had almost 60 folks on the show. So
great.
Apparently this is still very important to people. Either that or they're just waiting on their pizza to get delivered. They're trying to kill some time. I don't know.
I'll take it either way. Don't worry.
Casey, thanks for setting all this stuff up too. Do you have anything you want to announce or say? Did everybody get Casey's monthly newsletter today? There's another good one.
Lots of information in there, including the conference date. And stay tuned for more happenings.
Yeah, and John Dean is going to be starting a speech class, a speech program, March 3rd?
3rd. Yeah, we'll have an email about that. It's a free 10-week program that's virtual.
Yeah, and John, if you're not familiar, John and Joseph have done a number of programs with us, and he is one of the big dogs in the Parkinson's speech world. He's done a lot of research. He's on a number of boards of, foundations and organizations related to Parkinson. He's a great guy.
All right, guys. Well, thanks for attending.
Hey, everybody,
come back again next
safe.
Month.
Don't go out if you don't have to.
Stay in
I'm
if
looking
you
out
can.
the window here, and all our trees are covered in crystal, it looks like.
Stay in if you can, and we'll see you again next month.
Yeah, thank you.
Bye, guys.
Bye.